My topic: Lo does methotrexate for the prevention of atherosclerosis event. Definition: Atherosclerosis happens when the blood vessels and organs of the body become diselastic, sometimes restricting the flow of blood to organs and tissues. Healthy arteries are flexible and elastic, but over time, the walls of the arteries can harden, a condition called arterial hardening.
Welcome to True Health Tuesdays, and the truth will set you free. Atherosclerosis. Okay, last week it was fun. We were talking about cholesterol. Can you imagine starting a group? Last week was fun. We were talking about cholesterol. And today we're going to talk about hardening of the arteries. Oh, joy. What a sick group of people. Okay, so no, well, when you look at this, okay, we're breaking belief systems. So this is going over what people think is going on to waking you up that your body is intelligent. It reacts to the environment correctly. So there's nothing you need to be afraid about. So atherosclerosis, hardening of the arteries, is this a disease or an adaptive response? This is going to be weird. The National Institute of Health, talk about atherosclerosis, is when plaque builds up inside your arteries. Your arteries are blood vessels that carry oxygen and nutrients in the tissue. Plaque is made of fat, cholesterol, calcium, and other substances found in the blood. Just floating around, they form this. Atherosclerosis can lead to serious problems, including heart attack, stroke, and death. Dangerous. Really? Okay, so this is how it's supposed to form. Now, don't anybody ask, why doesn't it clog veins? Don't. I knew there'd be one person here. Okay, what I want you to look at, this is a representation of an artery. The plaquing occurs underneath the middle layer. Now, it's important that you understand arteries have a different structure than veins. They're totally different. They actually have three layers: an outer layer, a middle muscular layer, and an inner layer called an endothelial lining. Now, this stuff that's floating around in the blood, for some reason, starts to form a plaque underneath that cell layer. So it's not stuff just floating around. And what you're going to find out is that this is actually a reaction to some type of problem with the artery. Now, we need that muscular layer in the artery because it's going to constrict and dilate. So when you're under a stress response, you're going to have constriction of the blood vessels that supply the gut. You're going to have dilation of blood vessels that supply the arms and legs. So the blood literally flows from the gut area to run away. When you're in a parasympathetic or appropriate nervous system response to rest, digest, and repair, you're going to have vasodilation of blood supply to the gut and organ system. So the arteries have to constrict and dilate. Now, last week when we were talking about cholesterol not clogging arteries, we actually, I was kind of hoping he'd be here this week too. Somebody that was confused that thought that cholesterol, big fat globules floating around in the bloodstream, clog arteries. And I said, well, if that's true, clogging the small arteries, then the capillaries should clog up and we'd be walking around with black fingers and toes. So look at this. The plaquing forms underneath the cellular layer. So knowing that the artery has a muscular layer, there's also small arteries that lead outside of this artery to that muscle. It's a muscular layer. It's a muscle. It requires artery, or it requires blood supply. So there's little things called vasovasorums, or blood vessels in the blood vessels. So we really got to look at this process as to why is it forming underneath that cellular layer. Does that make sense? So you're reading in the research, okay, and you find this in Physiological Reviews, published October 2004, Role of Oxidative Modifications in Atherosclerosis. And they talk about how inflammation needs to be considered as the primary process of that hardening of the arteries. And I'm thinking, inflammation, well, that's a repair process. So where does the arterial...
Symptoms: If you have arteriosclerosis in the arteries of the heart, pain in the chest or pressures. If you have arteriosclerosis in the arteries leading to the brain, you may have signs and symptoms such as numbness or weakness, difficulty speaking, temporary loss of vision in one eye, or dropping of facial muscles. If you have arteriosclerosis in the arteries that lead to the kidneys, high blood pressure on kidney failure. Treatment: medication to lower cholesterol, regulate blood sugar level in the diabetes and control blood pressures. Metatrexato. Metatrexato is high doses. It is indicated for treatment of some types of cancer, such as gestational trophoblastic neoplasia or in acute leukemia and non-Hodgkin's. Metatrexato in low dosing is indication for the treatment of different types of arthritis, such as activities and severe rheumatic arthritis in adult patients, and activities and severe polyarticular juvenile idiopathic arthritis. When the repose to one steroidal drugs, the treatments on psoriasis and psoriatic arthritis when other treatments have failed. The treatments of Raynaud syndrome when other treatments have failed. In patients treated with low doses of metatrexato, lymphomas may appear that might suffer regression of the withdrawal of metatrexato, which in being necessary to start with a cytotoxic treatment to a weakness to flow could be to discontinue metatrexato first, and in case the lymphoma do not send, the appropriate treatment should be established. In patients treated with low doses of metatrexato, lymphomas may over that might suffer regression after the withdrawal of metatrexato without it being necessary to start with a cytotoxic treatment. The giveness to flow could be to discontinue metatrexato first, and in case the lymphoma do not send, the appropriate treatments should be
So the cardiovascular inflammation reduction trial, for me, is fascinating because at first sight, the implications are, here's a negative trial, but actually it tells us something really interesting about the biology. We know that the IL-1 beta, IL-6 pathway from the inflammasome is implicated on the basis of the previous CANTOS study. Now here's a different approach without selecting individuals at high CRP. Using amount of methotrexate that was sufficient to influence the hematological markers, but it did nothing. And it did nothing to the IL-1 beta, IL-6 pathway. So I think that this tells us that that pathway is crucial in terms of modifying inflammation and plaque behavior.
I was surprised it didn't lower C-reactive protein, and Dr. Richter is the PI. So why did Dr. Richter choose a drug that doesn't lower C-reactive protein to test? But it certainly is a nice trial to show that you can't just use any old anti-inflammatory drug. You have to use ones that meet specific pathways. And certainly with the results of the CANTOS trial, the IL-1 pathway appears to be the one to approach. But it didn't disappoint me or discourage me about the idea that directly targeting inflammation can still be beneficial for cardiovascular patients.
I think that with each of those trials, we've got to specifically look at that pathway. And we've got to look at the questions of, is the extent of dose sufficient to modulate that pathway in the plaque? Because if not, we may be facing another negative trial. There have been some interesting trials with colchicine already that look encouraging, but they were small.
And so I would like to have some sort of direct anti-inflammatory agent that has been demonstrated to help cardiovascular patients available to my patients. And then I'm also excited about the LODOCO 2 trial because colchicine is inexpensive. It's been shown to be very safe. It's already used for not only treating gout, but for treating other cardiovascular things such as atrial fibrillation and pericarditis. And so it might just fit right in if it becomes evidence-based by the LODOCO 2 trial. So I'm excited about that. And I'm also excited about other agents that might be targeted now that people know which direction to go. There have been other anti-inflammatory agents that have not worked, and so now we might have some that will work, especially now that we should probably concentrate on the IL-1 pathway.
Conclusion. In conclusion, the search trail showed that low-dose methotrexate didn't reduce atherosclerosis events, but it also didn't reduce markers of inflammation, so it neither confirmed nor refuted the inflammatory hypothesis of the atherosclerosis. The main takeaway is that inflammatory therapy might not have an impact if there isn't a lot of inflammation at baseline, or if the agents chosen doesn't actually decrease inflammation.